Now what is very severe? Let me draw for you. So kidney will be enlarged. So now pelvis is dilated, major calyces are dilated, minor calyces are dilated, and kidney looks like a bear claw. Okay, and a little cortical area you will see here. Okay, so now kidney will be severely dilated, all collecting system. So this is severe hydronephrosis. So then what's going to happen? More the hydronephrosis, more the pressure inside the kidney. And more the pressure inside the kidney, more the destruction of the renal cortex. So this patient, if this pressure is not reduced, this cortical tissue will be dead. So this kidney, this patient needs, if it is a bilateral, this patient needs renal transplantation. But nowadays, they do a great surgery. They can decompress or reduce the pressure. How? They will do the surgery. They will make a stent. They will make a stent and is connected with the bladder. So this is a stent. Okay, and they can save the kidney. Okay, so nowadays it is it's savable, but we have to look for what could be the causes of this type of very severe hydronephrosis. Is it a unilateral or bilateral? Then look for the causes. Okay, so this is hydronephrosis. And what is pseudo hydronephrosis? Pseudo hydronephrosis is false hydronephrosis. It is not there is no true causes. Pseudo means false. Pseudo means false. It is most of the time it is the reflux of urine from the bladder to the ureter and the ureter to the renal pelvis. Why? Because the bladder is too full. So bladder is super full. Super distended. Bladder is super distended. As a result, what can happen? The urine will come through the ureter, and the ureter as the renal pelvis, you will see the pelvis is dilated. If you see the pelvis is dilated, check the other pelvis. Both pelvis are dilated. But patient has never history of hydronephrosis. Then look the bladder. If you see the bladder is distended and there is a bilateral hydronephrosis, looks like a nephrosis, then ask the patient, oh my God, your bladder is full, go to the bathroom, empty as much as possible. And you have to take this picture for radiologist with this situation. And the next time when the patient come back, then scan the patient. Then you will see the bladder is empty, only a little urine is in there. And you will see the kidney is having no hydronephrosis. Kidney is having no hydronephrosis. So you have to take this picture for radiologist. So radiologist will say, yes, this is before the voiding, I see dilated, after the voiding, there is no dilatations. So this is pseudo hydronephrosis. So what would be the advice to the patient? What would be the advice to the patient? Never ever hold the urine. Every 2 hours, go to the bathroom, empty. But it is more common to the female, because the female, they usually, their holding capacity is more than the male. Okay? So then we understood this. Now, pyonephrosis. What is pyonephrosis? Pyo means pass. Pyo means pass. Instead of urine, it is pus. How did the patient get pus? Because of the infection. Okay? Infection. So somebody developed pyelonephritis. Okay? And the pyelonephritis, result of pyelonephritis, the pus. Where is the pus? The pus is in the pelvis. And pelvis, then major calyx in collecting system. So this, if this is the pus, the pus will give you the history of severe fever, right? High rise of temperature, pain, serious pain, and do the urine test. What are you going to see? The color of the urine is changed, cloudy, because of the pus, and it could have the RBC, hematuria. Then lot of cast epithelial cells are in the urine. You settle the urine for 1 hour, you will see half of the bottle or test tube is filled with sedimentation. So this is, and also in the urine there will be plenty of pus cells. So if this area is filled with pus, we call it pyonephrosis. We call it pyonephrosis. And the sonographically, pyonephrosis is echogenic. You will see instead of anechoic in the pelvic cavity, major calyces, you will see there are patchy area of hyperechoic in the pelvic cavity. So, and it has to match with the patient's history, physical examination, urine test, and WBC count will be very high. And you will get the patchy area of hyperechoic liquid materials. It is pyonephrosis. Okay, so that is very important, pyonephrosis. So now I will go over the renal artery aneurysm. This is, okay, renal artery aneurysm. What is aneurysm means? Abnormal dilatations of the artery greater than the 50% of its basic diameter. That means if the diameter is 2 centimeter, so 50% of 2 centimeter is 1 centimeter. So then 2 centimeter plus this 1 centimeter is 3 centimeter, right? So that's the way they calculate. If it is, that's why aortic aneurysm is considered when it is 3 centimeter or greater than 3 centimeter diameter. We call it aortic aneurysm. So renal artery aneurysm. So if this is the kidney and the renal artery, what is my red one? Give me. Renal artery is coming into the kidney from the aorta. So this is aorta. Okay. Now this is right renal artery and this is left renal artery, and these are the common iliac arteries. So keep that in mind. This is the distal aorta. The most common site of the aortic aneurysm is distal part of the aorta. And when there is a distal part aorta aneurysm, it extends upward, it extends downwards. When it extends upward, then it involves the renal artery. That means renal artery, look at here. So this is aneurysm, considered as aneurysm. It is involved in the aortic aneurysm, and definitely this will be like this. And if it is extended downwards, then you will see it involves the common iliac artery dilatations. So neither way is good. So if you see aortic aneurysm, you have to check the renal artery aneurysm. So another way renal artery could be aneurysm, that's the renal artery itself is dilated. Okay? So if there is a renal artery aneurysm, then what's going to happen to the kidney? So when there is a renal artery aneurysm, you will see the diameter is increased greater than 50% of its normal. And then you will see that blood is coming here and there is a turbulence started. Okay, you will see the turbulent flow. Turbulent flow. And turbulent flow is not a good flow. It's a slow velocity. And there is always sedimentation. So as a result, there will be thrombus formation, blood clot. So as a whole, apparently looks like it is more dilated, but at the end it will be more narrower because of the thrombosis. So these are thrombus. then what happened? The kidney is getting enough blood? No, practically it is not getting enough blood. So renal artery involvement. Renal artery could be stenosis. Renal vein could have blockage. So what would be the effect of the kidney? Understand. Renal artery stenosis, then occlusion. What is occlusion means? 100% block. Stenosis is less than 100% block. When somebody says 100% occlusion, it is occluded artery. That means 100% block. So renal artery, look at the idea. It's a renal artery. And it supplies the renal kidney, right? The kidney has its normal anatomy. This is the renal artery. In anatomy I showed you. This artery will be splitted and finally this artery will supply the blood in the cortical area too. Everywhere, right? Now, if there is a stenosis of the renal artery, so this is stenosis. If you see that there is a stenosis, but this stenosis is not greater than 50%, then I will say this is not a flow limiting stenosis. That means the flow will be intact. Flow will be intact and the kidney is not suffering. So now, if the stenosis is getting bigger, okay, and this is stenosis, say, I will say greater than 50%. Means it could be 79%, 85%. So then what going to happen? There will be flow limiting stenosis. If this is the flow limiting stenosis, that means less blood going to kidney. So if less blood is arterial blood is going to kidney, then what gonna effects on kidney? If there is a flow limiting stenosis of the renal artery. So what you're going to see? The size of kidney decreases. Number 2, echogenicity. Cortical echogenicity will be increased. Okay, cortical echogenicity will be increased. Then renal functions. Renal functions will be decreased. So as a result, you will see the increased blood urea nitrogen and increased creatinine. Okay, And it could be unilateral, it could be bilateral. So what's going to happen? The blood pressure will be increased. Blood pressure will be increased. Okay, so now less blood is going inside, and then what happened? Resistivity index is increased. Resistivity index is increased. Then you will see resistivity index is greater than 0.7. That means it will be greater than 0.7. Okay, you need to know these things. Now, I will say renal vein. If the renal vein so that I discussed, that is renal artery stenosis or occlusion. Now I will show you the renal vein. Renal vein obstruction. You have to understand that renal vein is returning the blood from the kidney. Right? Renal vein is returning the blood. Renal vein is returning the blood. So this is left-sided renal vein. Okay? So it is joining with the IVC. It is joining with the IVC. If any cause that make the renal vein thrombosis or metastasis to the renal vein, or the IVC here have blockage due to metastasis or DVT. Okay, so this is block, this is blockage. So then what happened? The venous return. What's going to happen? The venous return
backs up into the kidney.
backs up. Okay, so now this venous return will be no venous return. So then what's going to happen?
The kidney gets larger.
The back up to the kidney. Then you will see the venous flow is reverse venous flow, and the venous renal vein distal to the obstruction will be dilated. Number one. Reverse venous flow or no flow at all. Then venous dilatation distal to the obstruction. Then you will see presence of blockage, and you will see renal or kidney size will be increased, kidney echo will be decreased due to venous congestion, then renal artery flow will be resistive flow, and RI, resistivity index, will be higher. And finally, you will see renal artery may have no flow. No flow because of parenchymal resistivity index increase. Why parenchymal resistivity index goes increase? Because the vein is not returning the blood. As a result, the congestion is getting more and more and more, and the kidney is suffering from higher pressure inside. So if this is a situation, so then kidney size will be bigger. Why? The kidney is too much pressure inside, and kidney echogenicity will be decreased. Echogenicity will be decreased due to congestion. Okay? So now, neither way the kidney is safe. Neither in the arterial occlusion or the venous occlusion. Kidney is going to die. Kidney is going to die. Okay? So you have to know that. And they ask question, you saw a mass in the kidney, say renal, you feel like it is renal cell carcinoma. So what is the next structure you have to look for? If you feel this is the RCC, then you have to understand that there might be some metastatic. If there is a metastasis, it could be the renal vein or IVC. Okay? This is very important to know that if you see the kidney has a mass, you feel like renal cell carcinoma. Renal cell carcinoma metastasis takes place in the renal